Down a dark and lonely road lurks a shadow that is broad, sneaky, and unknown to the ignorant, and lethal as... Okay, I'm not sure that I thought this through. Okay, it is lethal as poison. A little poison at a time goes unnoticed until one day the lights go out. Clink! The shadow smiles now, leaning over its victims, and says wryly, "Oh, what's wrong? Is your speech slurring? Can only one half of your body move? What do you mean your vision field is disturbed? Oh, tisk, tisk." The shadow moves on to the train stop, where another victim sits on a cold bench, reading a newspaper, when snap! It happens to another. This time, the shadow's victim sits on the bench and twists its mouth to utter, "So what happens now that you're not going to make urine anymore? How about that? You better put that drink down because you're probably over the 2 liters for the day anyway. Enjoy dialysis. Maybe it'll give you the opportunity to be more social." In a plume of smoke, the shadow disappears off again to complete its last hit job of the night. This time, it was a family man. There, the silhouette of the shadow motionlessly watching the family man run around the yard in a game of tag with his children, when pop! The man slumps to his knees and gasps for air. As sweat beads on the man's face, the shadow whispers, "Tick-tock, tick-tock, and so your ticker may lose its talk. Tell me, does the weight of an elephant sitting on your chest matter if it's a baby elephant? Hope that ejection fraction doesn't reject the heart transplant that you're gonna need. Tick-tock." And with a blink of an eye, click, the shadow man is silently sneaking away to cause death and disability in about 80 million more Americans. So I was aiming for that to be a thought-provoking storyline and it would allude to some inspiration, but I'm actually feeling kind of depressed and sad now. I mean, how are those kids going to make it without their father? Well, okay, so how do you make a comeback from that horrible intro? Okay, I know. Students, hypertension does not have to lead to stroke, kidney failure, or heart attacks. We can stop this shadow monster, this silent killer. Can't be silent if we are participating in screenings, like at health fairs and such, and having patients do their annual evaluations with us. Before we sit down and begin talking about blood pressures, we need to remember some numbers. I bet from PCC1 you might have remembered hypertension begins at, say, 130/80. This is true in that we won't start medication if a person's blood pressure is, like 135/85. But for that, we will do lots of teaching and diet modification maybe. As we age, we will permit a little bit higher of a blood pressure because of the increased risk for orthostatic hypertension. And God knows all an older person needs is a low blood pressure, then they pass out, and now they fall, and now they break a hip, and their life expectancy is less than 5 years. Right, so we are going to give some respect to our elders and their blood pressure by letting anyone over the age of 60 have a blood pressure all the way up to 150/90. And then after that, we'll begin treating them. Let me actually say it in a different way. This is Kane Tanaka. She is a Japanese female who is 116 years old. If you were to take her blood pressure and it was 148/88, what would you do? Would you call the doctor and request blood pressure meds? Would you modify her diet? Would you ask her to lower her salt intake? Actually, you're probably not going to do much of any of that. You're going to do nothing. Exactly. For anyone greater than 60 years old, we should begin treatment for hypertension if their blood pressure gets greater than one, how did I say that? Anybody who's greater than 6 years old, we should begin treatment of their blood pressure if it gets greater than 150/90, if they're greater than 60. Now, there is no correct age to begin treatment for blood pressure. Just know the magic number 60, and the treatment for them starts if their systolic blood pressure is 150. Everyone else, age besides the point, gets treatment if their blood pressure is greater than 140. That's talking to you, 15-year-old person with a high blood pressure. Men more than women have higher cases of high blood pressure until about the age of 64 years old. Then, in that situation, women begin to have more cases of high blood pressure than men. So, how does high blood pressure even happen? Well, it begins because the pressure in the arterioles is high, and that leads to arterial thickening. And now the heart actually has to pump harder against the resistance, and then now more plaque is going to be placed on the damaged arteries, and then the arteries are going to narrow even more because of the plaque and the thickening, and they are going to become less compliant. It's sort of a hot mess. These changes in the body that are going to happen over time can lead to very poor outcomes such as MI, peripheral vascular disease, strokes, and kidney failure. None of that sounds like a good time, so let's look at the contributing risk factors. Now, looking at that list, which ones do you think are modifiable? Please don't say family. You can't help who they are. Just love them as they may exist and be. Then there are these other diseases that can actually cause hypertension. And if you get rid of that disease, then the hypertension actually will go away. Now, by no means am I asking you to memorize the list here or the list in your book. I just kind of want to point a few things out to you. Particularly speaking, Cushing's disease or Cushing's syndrome. This is where you have high secretion of the adrenal hormone, or if somebody is taking lots of steroids such as prednisone, over time it can actually cause sodium and water retention and all these other Cushing-like symptoms you see on this picture. Medications that I have listed here, the ones I'm thinking of are estrogen, and of course prednisone, cyclosporine, which is actually a medication for chemotherapy, for cancer I should say. It's a chemotherapy and it's for cancer, and other sympathomimetic drugs such as epinephrine and cocaine and amphetamine. All of those can raise blood pressures. African Americans have increased incidences of hypertension. They develop it earlier in life, and this means that they are much more likely to die of heart disease, strokes, and kidney disease than are Caucasian persons. Ask about someone's activity level. Do they exercise 3 to 4 times a week for 40 minutes or more? No? Yes? What does their diet look like? Ask them to do a diet recall or maybe even a diary. For the physical assessment piece, know that oftentimes when there is a diagnosis of hypertension, it's really made when the person is asymptomatic. Oftentimes it's made when a person is asymptomatic. So how do they get diagnosed then is probably what you're thinking. Well, it's through our screenings again and through our yearly well checks and physicals. I do need you to know some symptoms though of high blood pressure, and it's usually symptoms because it is very uncontrolled and very elevated. 180/20 elevated. So those signs and symptoms look like a flushed face. They are going to complain of dizziness and severe headaches. Also, they're going to complain of blurred vision. Now, if we were to put a stethoscope on them, we may hear some abdominal bruits, which is swishing over, say, their renal arteries, and that is due to non-compliance of the vessels. We're not going to hear much on the heart or in the lung fields. It would actually be a good idea to get a fundoscopic look in the eye and to look for cotton wool spots, hard exudates, and flame hemorrhages. This takes extra training though to be able to detect these issues, so we can always take a look, but you may not know what you're looking for. But it's good to know these terms for a test that you may take in the future, such as the NCLEX. They actually say that the fundoscopic screenings are the future for hypertension screenings because patients may be able to talk their way out of it. If you detect a high blood pressure per se on your screening, they'll say, oh, well, I had a salty breakfast, or I'm just feeling anxious. I have that white coat syndrome. Well, the eyes don't lie. The eyes, they see everything. The eyes. Okay, I'm creeping myself out. For your blood pressure assessment, we really should take the blood pressure in both arms on multiple occasions. For obese individuals, forearm blood pressures are actually okay and are considered accurate. And just a heads up, this is a proper forearm blood pressure. There you go. See how the little prongs go towards the patient? I actually posted a video in the module about how to take a blood pressure on a patient who is morbidly obese. And FYI, nurses are only allowed to have natural nails when they are caring for patients in the patient care areas. Busted. Now, do make sure to get the appropriate size cuff for your patient. And I honestly want to take a moment to do a shout out here. This is a huge pet peeve of mine, that if we are taking a blood pressure and we're using the wrong size cuff, and then we begin to make decisions off of these numbers, this is bad practice. Just go get the correct size for your patient, and if you're not sure, go look it up of how it should fit. Now, if you do notice that you grabbed the wrong cuff and your patient needs a larger one, please, 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 please do not be that person who says, oh, let me get a larger cuff. This is too small. It doesn't fit. Your arm is too big. That's honestly a very tender spot for our patients. So instead, I need you to go and say, I'm going to get the appropriate size cuff for you. This is a this is cultural sensitivity training that just happened and you didn't even know it, did you? All right, psychosocial assessment. What are their stressors and what is going on with their coping strategies? Do inquire about this. We also need to assess how they adhere to treatment. I usually say to my patients, would you rather cut back one less per day of alcohol or maybe smoking, or maybe like one less per week? It's honestly a starting point in the conversation about stressors and cutting back. In fact, sometimes you might even try to phrase things so your patient can't tell you no. I will say to them, on a scale of 1 to 10, how hard would it be for you to cut down on your drinking? 7, is what they say. Okay, well, why didn't you say 8? Well, I feel like I enjoy drinking, but it's more of a 7 than an 8 because I'm not addicted or anything. I can stop anytime. Sure, I say, wink, wink. But I actually agree with him. I'm like, I bet you could. Now, what I do is in my next interaction with a patient, I usually say, okay, well, you said you were a 7. I was just kind of wondering if we could think of something to do to make it less hard for you to cut back on your drinking. So how can we move your 7 to a 6? Now, this approach doesn't work all the time whenever I'm trying to assess their adherence to medical advice. In fact, I tried to use it to encourage a grandma to quit smoking weed one time. Nope, that was not happening. She was not going to quit smoking no matter what I did or did not say. Yeah. Okay, last but not least, lab work. Miss Tonis, is there a lab draw to tell us if a patient has hypertension or not? Nope. No, sir, no, ma'am. There isn't. Is there an x-ray? Nope, no x-ray to detect it either. However, we actually may see cardiomegaly, which can be present in long-standing hypertension, so like in a large heart. Well, what test are we running then, you may ask? Okay, well, we can do a creatinine clearance test on their urine. This can tell us if the glomerular filtration rate is slowing down and if a patient is passing more creatinine through their urine or less creatinine through their urine. This lets us know if our patient's developing nephropathy. Well, we can also do an EKG. This can be done and is an early indicator of cardiac remodeling, and cardiomyopathy may be setting in. So if we do an EKG, we can catch it before cardiomyopathy shows up on the EKG. Okay, lifestyle modifications. Salt restriction. It is recommended for patients to restrict about their salt intake to 1,500 milligrams to 2,400 milligrams per day. It really just depends, but that is your range, 1,500 to 2,400 milligrams of salt per day. The next thing we need to recommend to our patient to do is weight reduction. Let's try to help them get back into their normal BMI range, which is about 18.5 to 24.9. That guy's really working it. The next thing we need to do is reduce alcohol intake. The recommendations are 1 drink per day for women and 2 drinks per day for men. We should encourage them to reduce their caffeine intake too. That's painful for me to hear. I love my caffeine. Okay, exercise. And you may have already kind of remembered that I mentioned it earlier. They should exercise 3 to 4 times per week, 40 minutes each session with like moderate vigorous activity. We should encourage our patients to decrease their stress level. Anything to make yourself calm, like painting happy trees. Thanks, Bob. And avoid smoking. Did you know that nicotine patch dosages are based off of how many packs of cigarettes that a person smokes in a day? So a pack per day earns someone a 21 milligram nicotine patch. If they smoke half a pack a day, then they will get a 14 milligram nicotine patch. Makes sense. Then if they smoke like say a quarter of the pack, then the doctor will order 7 milligram nicotine patch. I say this to you because I had a patient who was mean as a snake, irritable and couldn't be pleased and so forth, just angry. And during MedPass time, I had to give her a 14 milligram nicotine patch, and I asked her how much did she smoke, because I was suspicious that she was being undertreated with her nicotine withdrawals. Well, when she replied that she smoked a pack and a half, I knew then to call the doctor and let him know what the patient's response was to my question, and he ordered me a 21 milligram patch. Whew! That patient was now less grumpy and less evil. Nicotine withdrawal can make patients act just so nasty and rude. So in your future nursing practice, if you have a rude and nasty patient, you may want to just ask them and clear the air, how much do you smoke? Or perhaps do you smoke? They may be going through nicotine withdrawals. Whew. much of this information you may already know, but it never hurts just to review it. Garlic and coenzyme 10 are medications that you might see used in patients who have high blood pressure, but it's actually pretty controversial if its use is helpful or not. It's not so much supported in the evidence that it is effective, however, people still do it. Do know that garlic can cause liver damage and it can thin the blood a bit too much and make someone prone to bleeding. So if they are on garlic for their blood pressure, they need to discontinue it prior to, say, surgery or any kind of invasive procedure. Okay, beta blockers such as metoprolol. It's a cardioselective beta blocker. It is the drug of choice if ischemic heart disease has been or is present. Do watch for that hypoglycemic side effects that we can have of beta blockers, such as masking the signs and symptoms as well as causing episodes of hypoglycemia. And if a person wants to suddenly stop taking beta blockers, we probably need to do so under a physician's direction because it can result in refractory chest pain. Make sure to double check a blood pressure, obviously, prior to giving a beta blocker. It should be greater than 50. That's 50. Diuretics. This is the first of our diuretics. Hydrochlorothiazide, a thiazide drug actually. This is the drug of choice for patients who have uncomplicated hypertension. These are fantastic. However, if a person, if it's really important to them to have a good sex drive, this could actually decrease their libido. We probably cannot give hydrochlorothiazide if a person has gout or hyponatremia because it will actually worsen those situations. Do know that hypokalemia is a real problem with this medication, and meaning it will deplete them of potassium. So what does low potassium look like on a patient? Well, it looks like irregular pulse, dysrhythmias, and it looks like muscle weakness and flaccid paralysis. Actually, I'm going to have to take back that flaccid paralysis. Let's just leave it at muscle weakness. Okay, the next diuretic that I would like to talk about is loop diuretics. Loop-de-doo. I keep doing that trumpet sound. These drugs are notorious for causing postural hypotension and dehydration, so they are very effective at pulling fluid off of a person. But just like our thiazide diuretics, we need to watch for hyponatremia and hypokalemia. Encourage them to eat some bananas or potatoes, drink some orange juice. That actually is very high in potassium, actually. Okay, another diuretic I'd like to bring to your attention are the potassium-sparing diuretics, such as aldactone. Another name for this would be spironolactone. These are fantastic medications in that we can give it to somebody that's actually receiving a loop diuretic or a thiazide diuretic, and that the end result is the potassium will be quite normal. I know, right? How cool is that? Who thought of this, huh? Do know that if a person is taking a diuretic, would you rather have them take it in the morning, maybe at lunchtime, or in the evening time? Hopefully you said morning time or lunchtime. We do not want our patients taking diuretics right before they go to bed. They will be quite upset with us if we try to administer it at that time. Okay, another medication we can give are the calcium channel blocker family. This is actually the most effective drug class for our African American populations and for our older populations. Do make sure that we do not allow a person to drink grapefruit juice. what will happen if they have this medication on board? Actually, I think I'm behind a picture. Ah, that's much better. I apologize. There's my calcium channel blocker. Okay, if our person drinks grapefruit juice and has this medication on board, the grapefruit juice will actually not allow the drug to be broken down by the liver and excreted. So we're going to have basically drug toxicity if they take grapefruit juice. Next thing I want to point out are ACE inhibitors and our ARBs. For the ACE inhibitors, do watch out for that dry, nagging cough, and if they do develop that cough, they need to come off the medication and probably be placed on an ARB. If we place our patient on lisinopril, do know that older adults can have profound orthostatic hypotension, so make sure we give them their first dose and watch them carefully for that. Remember that problem that causes swelling of the lips and of the face and of the upper oral airway? Remember that name? It's associated with the ACE inhibitors. All right, angioedema. This is a real possibility. So do watch if it's their first dose that they don't develop any complications of angioedema. Okay. ARBs. And these two drugs are very much preferred if a person has heart failure. So hopefully we can get them on these medications because it does a great job for remodeling of the heart. Okay, hypertensive crisis, one of our last slides here. I've actually seen one or two cases of this in my day. We had this one 45-year-old female. She came in with this and we had to immediately admit her to the intensive care unit because we wanted to put her on a vasoactive drip and slowly lower her blood pressure down over the shift. So we did that so she didn't develop seizures or have a myocardial infarction. She unfortunately had a hypertensive crisis because she did too much crack cocaine in one sitting, and that means she was quite the wild patient. I really wish I could tell you more of what went on that shift, but we don't have enough time because it was crazy. It's definitely one I will never forget, I'll tell you that. All right, one thing she complained about was having stabbing, throbbing headaches. This is a common complaint for those with hypertensive crisis. What we want her do you want to know what her admitting blood pressure was? It was 230/130. Yeah, I know. How do you think her vision was doing with that high blood pressure? Blurry, right. And she was super anxious. But I would be lying if I didn't admit that I thought her anxiety was more of the cocaine than it was actually due to her high blood pressure. But I don't know. Anyway, for this patient and for any patient in a hypertensive crisis, please place them in a high Fowler's position. We want to decrease the gravity's effect on their head, so definitely no Trendelenburgs. And we ended up giving her 1 liter bolus of IV fluids. Wait. What do you think I was correct in that I just said that? That we gave her 1 liter bolus of normal saline? Did you actually catch that? That is actually an inappropriate thing to do, so I'm glad you caught that. What are IV boluses for? They're for patients with low blood pressure. All right, so we've got our high blood pressure patient. We can start an IV and we can give them a little bit of saline just to keep the vein open, but definitely no bolus of saline. You need to question that order if that ever comes through on this patient. Okay, back to the story. This lady did receive the drug Cardine, and we monitored and titrated the rate of the Cardine drip all night long. We probably took her blood pressure, I think, about 100 times in a 10-hour period. But Her blood pressure did eventually go down. I think before we left our shift, we got it down to about 150. I think it was over 99, and then we ended up discontinuing the medication and put her on PO meds. All right, that is all I had to say for hypertension. I hope you learned something.